Hi everyone, my name is Med2Med. Today's session is going to be about sodium levels. These notes are based on the following resources. I've been using Scott's Notes, the Oxford Handbook of Clinical Medicine, and the NICE Guidelines. As a disclaimer, I am a third-year medical student. This video is not intended to be a substitute for any professional medical advice, and you should always consult your doctor about any health concerns. Sodium has some amazing and brilliant roles in the human body, but for the purpose of this lecture, we're going to be thinking about its two main purposes: keeping fluid in balance, so that's maintaining blood volume and blood pressure, as well as controlling osmotic gradients, and nerve and muscle function. Sodium is naturally found outside of the cell, whereas potassium is found within. This means that when a sodium influx occurs, because it's positively charged, it depolarizes the cell and leads to an action potential. You can see this in step 1 and 2. Then the sodium channels close at the peak of the action potential and the cell is repolarized. Sodium is also involved in the renin-angiotensin-aldosterone system. We can see here the adrenal cortex secretes aldosterone in order to cause sodium reabsorption. This occurs predominantly in the proximal convoluted tubule. Normal sodium levels in the blood is considered to be between 135 and 145 milliequivalents per litre. Okay, let's look at the high end of the spectrum, hyponatremia first. Now remember, that's a sodium level of greater than 145 milliequivalents per litre. Let's explore the symptoms of hyponatremia. We have lethargy, thirst, weakness, irritability, confusion, and coma and fits, along with all the typical signs of dehydration. What might lead to this raised blood sodium? Well, this is usually due to water loss in excess of sodium ions. So that's fluid loss without water replacement. So things like diarrhea, vomit and burns. Diabetes insipidus can lead to hyponatremia. This is where there is impaired secretion and response to ADH. You might suspect diabetes insipidus if the patient is urinating large volumes and has a history of head injury or surgery. Then, osmotic diuresis can cause hyponatremia. Primary aldosteronism. So remember, this is excess aldosterone and it's causing this sodium reabsorption within the tubules as per the renin-angiotensin-aldosterone system. If there's increased aldosterone, there's increased sodium reabsorption. And lastly, incorrect fluid replacement like excessive saline can cause hyponatremia. How do we treat high blood sodium? Well, we give oral water if possible, and if not, we give 5% glucose via IV very slowly, then use 0.9% saline if the patient is hypovolemic. Let's look at the other end of the spectrum, hyponatremia, so that's low blood sodium levels. In these patients, we're looking for signs of anorexia. The patients may complain of nausea and malaise at the beginning, followed by headache, irritability, confusion, weakness, reduced consciousness, and seizures. So what causes hyponatremia? There's a really nifty flowchart you can use with a few questions you can ask yourself in order to determine the cause of the hyponatremia. Firstly, you need to ask whether the patient is dehydrated. If the answer is yes, then you need to ask, is the sodium being excreted via the urine? So that's if urinary sodium is greater than 20 millimoles per litre. If the answer is yes, then you're looking at these causes. As we've already mentioned, we know that sodium is being lost via the urine, so that's via the kidneys, and the patient is dehydrated, so water is also being lost via the urine. This can be caused by things like Addison's disease, so remember, this is adrenal insufficiency. If you think back to the renin-angiotensin-aldosterone system, aldosterone is responsible for triggering sodium reabsorption. But if it's not being made like in Addison's, then sodium will be excreted. I have a lecture on Addison's disease if you want to revisit this. And again, in renal failure, there's impaired tubular reabsorption. Diuretics, so particularly loop diuretics, inhibit sodium transport in the renal medulla. And lastly, osmolar diuresis is an increase in urination rate due to certain substances in the kidney. High serum osmolality drives water into the extracellular spaces and causes dilutional hyponatremia. Okay, then if the answer is no, sodium isn't being lost in the urine, then we know that it's being lost via other ways than the kidneys. So that's things like diarrhea, vomiting, fistulae, burns. You can see all the different causes listed here. Okay, so if the patient isn't dehydrated, then perhaps fluid is entering the interstitial spaces and the patient is edematous. If the answer is yes, then what causes edema? Well, we know nephrotic syndrome due to hypoalbuminemia, and therefore a low osmotic pressure causes fluid to leak into these spaces. I've got a lecture on nephrotic syndrome as well if you want to learn more about that. Then there's liver cirrhosis, which we know can cause edema and renal failure. Okay, so what if the patient isn't dehydrated and they're not edematous? Well, then we need to look into urine osmolality. If there is less than 100 millimoles per kilogram, then suspect syndrome of inappropriate ADH secretion. If there isn't a low urine osmolality, then suspect water overload, so severe hypothyroidism, glucocorticoid deficiency, which results in impaired free water clearance, leading to water retention and thus dilutional hyponatremia. Sometimes when you look at sodium levels, you can actually have artifactual hyponatremia, so this isn't true low blood sodium. This can occur if the blood sample was taken from an arm with a drip in it, if there is a high serum lipid or protein content, because this will increase the serum volume and decrease the sodium concentration. Lastly, if the patient is hypoglycemic, you need to add around 4.5 millimoles per litre to plasma sodium for every 10 millimoles per litre rise in glucose above normal. So with all of these, you're not actually looking at true hyponatremia. Then, doctors can actually cause hyponatremia by medication that they give to the patient. So for instance, if you give 5% glucose and it's infused continuously without adding 0.9% saline, the fluid will become hypotonic because the glucose is used up really quickly, and this leads to hyponatremia. Some patients who are particularly susceptible to these effects are those who are on thiazide diuretics, women, so particularly premenopausal women, and those under physiological stress, so for instance that's during sepsis or post-operation. So how do we manage these sodium levels? Well, it's all about determining how low the levels are and whether the patient is actually symptomatic. If the patient is asymptomatic but has chronic hyponatremia, then fluid restriction is often sufficient alone, but you can give demeclocycline if required. Also, if the patient is hypervolemic, like through cirrhosis or congestive heart failure, then you're going to want to treat that first. If the patient is symptomatic or the hyponatremia came on particularly suddenly, you give cautious rehydration with 0.9% saline. Otherwise, a phenomenon called central pontine myelinolysis can occur, which is due to this really rapid correction of sodium and causes, as per the name, pontine demyelination. Then you can give vasopressor receptor antagonists like Vaptans, and this is in order to promote water excretion without electrolyte loss. And lastly, in an emergency, you should get expert help and treat with a hypertonic saline, possibly with furosemide. So I mentioned SIADH before, but let's have a brief look. Essentially, this condition requires the following criteria. So there's concentrated urine, in the presence of hyponatremia, so remember we saw it in that diagram where it was the patient isn't dehydrated, but there is low concentration of sodium within the blood. with a low plasma osmolality, and in the absence of hypovolemia, edema, or diuretics. What can cause this? Well, it can be a result of malignancies, so that's things like small cell lung cancers and many others. It can be a result of a CNS disorder, like a stroke, a head injury, things like that. Chest disease, like TB or pneumonia. Endocrine disease, like hypothyroidism. And drugs like opiates and SSRIs, and other causes, like acute intermittent porphyria, trauma, or even major surgery. We know that in a healthy individual, when the patient is particularly dehydrated, our body releases antidiuretic hormone, ADH, in order to stop any urination and to prevent any more fluid loss. So this is what we're trying to correct. We treat it by identifying and managing what has actually caused this SIADH. Was it trauma? Is it a CNS disorder? Then we look at restricting fluid. You can also consider a salt and loop diuretic if it's particularly severe. Great, let's just briefly revisit what we've mentioned. So we now know that normal blood sodium is between 135 and 145 milliequivalents per litre. Aldosterone is released by the zona glomerulosa cells in the adrenal cortex. This increases tubular sodium reabsorption. Hypernatremia usually presents with thirst, nausea, weakness, and a loss of appetite, so this is high sodium in the blood. We usually treat hypernatremia with increased oral water intake, but if that's not possible, we can give 5% glucose via IV. The causes of hyponatremia are usually classified by body fluid into low volume, normal volume, or high volume, as well as osmolality and urine concentration. Urine is concentrated in syndrome of inappropriate ADH secretion. And lastly, hyponatremia can be artifactual. For instance, if you take a sample from the patient's arm with a drip in it, or if there are raised glucose or lipid levels in the blood, this can cause what seems to be low sodium levels in the blood, but isn't actually true low blood sodium. And that's it. Thank you for listening.